This is Dr. Mimi Lamb from Case Western Reserve University, and in this video we'll apply a couple of things that were covered in parts 1 and 2 of this dialysis physiology series and show you how we use them clinically. First, let's revisit the concept of clearance for a minute. Remember that clearance is defined as the volume of plasma per unit time, usually in mLs per minute, from which a substance has been completely removed by the kidneys and excreted in the urine. Having a mathematical formula for which the clearance of a substance can be calculated is just a fancy way of standardizing and quantifying how well our kidneys are doing at removing the substance from the plasma and getting rid of it in the urine. Remember that our 2 million nephrons, even in the same person, are of different sizes, different lengths, working at different levels of efficiency. For instance, some are damaged by age or diseases like diabetes or hypertension, so they don't all do an equally good job of clearing stuff. The clearance formula, by looking at the concentrations of substance X in the plasma and the urine, and the rate at which urine is being excreted, just takes all those little nephron differences and tells us how well the pair of kidneys as a whole is doing in getting rid of X. And that clearance number that is calculated for a given pair of kidneys at a given time can be compared with the clearances of normal kidneys, or of other people's kidneys, or of the same person's kidneys over time as they're damaged by age or disease, or as kidney function improves because of treatment or natural history of a disease. Another concept we can remind ourselves of from video number 1 is the 3 basic processes by which nephrons can affect clearance. Here's a renal tubule lined by tubular cells with a lumen in the middle and surrounded by capillaries containing blood. The first process affecting clearance is filtration. The more you can filter from the glomerular capillaries into the renal tubules, the more you can potentially excrete, and the larger volume of plasma you can clear of a substance such as sodium, water, urea, and creatinine. The second process is reabsorption. The more of a filtered substance you can reabsorb from the lumen back into circulation, the less you can potentially excrete, so its clearance will decrease. This happens for sodium, water, bicarbonate, and glucose, for instance. And the third process is secretion. If you can supplement the filtered amount by adding more from the blood and the surrounding capillaries, you can clear a larger volume of plasma of things like potassium, hydrogen ion, and even some meds like penicillin. Without even going through the math of deriving the clearance formula as we did in video number 1, we can see certain principles. First, clearance is higher if the kidney clears something like X efficiently. The simplest way to clear X is for it to be freely filtered at the glomerulus and not reabsorbed or changed or metabolized by the tubules as it travels all the way down. Then from the blood and urine concentrations of X and the rate of urine flow, we can calculate a clearance in mLs per minute. Say it's 100 mLs per minute. Then, for instance, if substance Y is freely filtered at the glomerulus but has a lower clearance than X, like 50 mLs per minute, this suggests that about half of the filtered Y is being reabsorbed by the renal tubules and does not appear in the urine, so the kidney is not getting rid of or clearing Y as well as X, and so the calculated clearance is lower. If it were not reabsorbed, then the clearance would be more like glomerular filtration, or 120 mLs per minute. And if substance Z is freely filtered but has a higher clearance than X, like 130 mLs for instance, this suggests that a pretty big amount of Z is being added to the filtrate by secretion from the surrounding capillaries into the renal tubules, thus increasing its clearance to more than can be accounted for by filtration alone. And so we see that kidneys can change the composition of glomerular filtrate quite a lot as it travels down through the nephron. and this is something that dialysis capillary fibers cannot do nearly as well. So now we're ready to talk about how we measure dialysis adequacy. All the calculations we're going to discuss are done by the computer in the dialysis machine. You don't have to do a thing except to look at the unitless number that comes out, which is called KT/V. The dialysis machine uses for its calculations things like urea clearance, which uses data from the dialysis machine pre and post blood urea concentrations, blood flow rate, characteristics of the dialyzer, and so on. It incorporates this data into a formula that also takes into account the length of the dialysis treatment and the total body water of the patient. And it calculates this unitless parameter called KT/V. So what is KT/V? It's a measurement for dialysis that helps us to quantify treatment adequacy for hemo or peritoneal dialysis. Remember that although the formula looks simple, there are some complicated mathematical assumptions and manipulations that underlie the calculation of the individual parameters. So these include K, the dialyzer clearance of urea, T, the time of dialysis or the length of treatment, and V, the volume of distribution of urea, which is approximately the total body water. So using these parameters, the dialysis computer will make some calculations and employ various formulas, assumptions, and corrections, and spit out a number that it calls KT/V. In this example then, K, the dialyzer clearance of urea, is 212 mLs per minute. The time of dialysis is 4 hours or 240 minutes. And the volume of distribution of urea is about 60% of total body weight. So for this 70 kilogram person, it's about 42 liters or 42,000 mLs. And the calculated KT/V is 1.23. So the machine spits out this number and we just look at it and sort of arbitrarily decide whether it means adequate dialysis or not. And there's some room for discussion and argument about exactly what constitutes adequate. But most clinical studies agree that a KT/V of greater than 1.2 means adequate dialysis. And many dialysis units actually use 1.4 as a cutoff just to be sure that their patients are getting enough dialysis. So this sounds simple enough, but of course there can be problems with using a parameter, a single parameter like KT/V, to measure dialysis adequacy. And I'm just going to list a few of them for you so you get some idea. First of all, KT/V, the formula tends to overestimate dialysis adequacy for small people and for women. It tends to be inaccurate in the estimate of total body water, because of course not everybody is made exactly of 60% water. It only accounts for urea removal, and there are something like 140 uremic toxins that get removed by dialysis. Some of the larger solutes can diffuse more slowly or equilibrate more slowly over cell membranes. And so when you measure KT/V based only on urea removal, things may be looking better than they actually are. And finally, it doesn't account for post-dialysis urea rebound, because one of the things that's used in calculating KT/V is the immediate post-dialysis blood urea concentration. And over a period of time, of course, urea starts to diffuse out of cells and back into the blood. And so using that immediate post-dialysis number can make things look artificially good. And finally, although it hurts me to tell you this, people have written about the KT/V that it is complex and tedious to calculate, and many nephrologists have difficulty understanding it. So you can get just a glimpse of some of the problems with using an oversimplification like KT/V to assess a complicated and multifaceted parameter like dialysis adequacy. But just keep in mind that we are looking for a practical measure that can be obtained and calculated quickly, easily, frequently, and inexpensively. and this is probably the best that we have in this day and time. So I hope that this video has helped you to understand a little better some of the basics of dialysis physiology. And as before, if you have any questions or corrections or comments that I can help with, please feel free to email me at this address. And thank you for watching this video.